Hello everyone, this is Braswell Dean, Department of Family Medicine, and we're going to go through a wonderful little injection, the shoulder injection. And before we did, I wanted to show you some anatomy here of what we're going to be doing. Now, we're trying to get into the shoulder joint here, and probably the easiest thing to tell you would be to look here for the posterior scapular ridge. And usually what I do is I'll palpate the outermost part of the shoulder, find this spot and go over a couple of finger breaths or two and then down and mark my spot right there. And then the injection itself, if I kind of visualize with my finger, I'm going to be going underneath that scapular ridge. And then once I'm in the shoulder joint, the injection should really be really easy, should flow very easily. And if I'm up against a bone or something like that, if I'm a little bit too high, just basically pull back and just have that sense of going underneath this anatomical structure here. A common problem is if you're on top of the posterior scapular ridge and you inject medicine, you'll begin to see the skin rise up here. So you'll know that you're not in the joint if you see that. But other than that, we're going to be just finding our landmarks. Sometimes it's a little bit more challenging if the patient is very muscular, but we're going to find our landmarks and then we're going to just go right for the injection. So we'll take a second and we'll take a look at this on the patient. Okay, everyone, we're back. This is our patient here, and as before, we're palpating the elements of the posterior scapular ridge here, and my fingers are sort of along that ridge. I could draw it out with a pen, but I'm just kind of showing you with my fingers. And my thumb is on the lateral part of it. And so you have to remember that the shoulder has the big deltoid muscle over on this side, and the actual edge of the scapular ridge is over here. So this is plenty of muscle over here. So this is one of these injections where you have to go by feel and understanding of the anatomy first and foremost. So when you find this area, you come down a finger breadth or so, and you can feel that indentation underneath that posterior scapular ridge, and that's where I've marked my spot. And I usually just use like a pen cap here just to mark the spot, so I'm not using any real ink on the patient. Now, when I think about the shoulder joint itself, I think about the anatomic position. The shoulder joint is over on this direction, so I'm going to be going underneath that posterior scapular ridge, just like we talked about before. Now, a word about these shoulder injections. The most common reason we do this is for rotator cuff tendinitis. The rotator cuff tendon is called the cojoint tendon or the supraspinatus tendon. There's a bunch of names for it. It's the most famous one because it starts from a muscle group back in the scapula and comes down the arm. And the attachment for the supraspinatus tendon is right here on the proximal humeral bone here. And so a lot of times patients will have pain when they sleep on it, and that's usually a bursitis setting up shop along this bony area here. Sometimes people will have numbness down the arm, and sometimes that is occurring because the nerves can get irritated as they get into this area of inflammation as they're traversing their way down the arm. That will be sometimes a finding in many patients. And then a lot of times the patients will have trouble abducting their arm in the lateral plane past 90 degrees. Now, to get to 90 degrees, this deltoid muscle does all the work. So everybody can get to about 90 degrees or 110 degrees. But a lot of times people with bad supraspinatus tendinitis or rotator cuff tendinitis will not be able to raise it above 110 degrees, or will have trouble when they're trying to oppose force. So we're going to just relax the arm here and get it back to a neutral position, and we're going to get ready to go ahead and start the injection. So again, I've located, once again, the posterior scapular ridge, the lateral part. This should be where we want to go. So the first thing I'll usually do is a little alcohol cleanup job here, just to get the skin flora off and cleaned up. And then we're going to put 3 cc's of lidocaine in first to give some good anesthesia. So I like to use good technique with your hands. I'm right-handed, so my left hand is my tripod. My right hand, I use that to sit on that base. So we'll we'll have a little something when I count to 3. My thumb, you'll notice, is an anchor. I'm anchoring the skin to keep it from moving because that helps the skin not hurt when we do the injection. So on 3, 1, 2, 3, right there. And we put a little, we're putting a little lidocaine in. I budget about a good cc to go in first and foremost, so nobody feels anything after that. And then I can redirect towards my injection angle, and notice my injection angle is here, and if I'm using my finger here to show you where that imaginary posterior scapular ridge is, that's where we're going. That sense of going underneath it. There should not be any resistance. And so now we put all of our lidocaine in the joint, and a good thumb massage. And we usually mix up the triamcinolone. Again, the second injection is 40 milligrams of triamcinolone. I put a little bit more lidocaine in because I budgeted for about I put 1 cc of lidocaine in the joint already. I'm going to put a couple more cc's in just for some local pain relief. So now, again, this is the proper injection angle. Before we were doing this in the angle. Now we're doing the regular injection angle because I'm wanting to go into the joint. So a little pressure here. And we're in the joint. And we're just going to put the rest of the medicine in like so. And that's it. This is a great little injection. It will kick in about 3 days, as all of our triamcinolone injections do. And hopefully, the old saying here with shoulder injuries or rotator cuff syndromes, if you don't use it, you're going to lose it. That's never been more true for the shoulder. And so again, good range of motion exercises, anti-gravity exercises are really important. Trying to identify what the precipitating problem is, using non-steroidals if the patient can tolerate it, physical therapy if needed, needs to really happen in addition to the shoulder injection if needed, because we want to maximize the recovery and the potential to use the shoulder going forward. Okay, thanks, and we'll see you next time.